welcome to everybody to this month's CCRSC webinar rounds. As you know, we've been going for quite some time now, and I think they just get better and better. So I'm Dr. Martin Chasen, and I'll be the moderator for today's session. First of all, I'd like to thank everybody that's joined us remotely. I cannot see, but I do know that there are a number of people that have joined us, and I'm very happy about that. And I'm hoping that we'll do the presentation and this will engender some kind of discussion that will be fruitful to everybody. So today we're going to hear from Anish, and after which, probably for about 40 to 45 minutes, after which we'll open up for questions and for discussion. And I'd like to introduce Anish Jammu, who I've known over 2 years. And she's been a student researcher with me here at the William Osler Health System. She graduated recently with an HBSc degree from the University of Toronto, and after looking around has decided on an MSc candidature studying global health at McMaster University. She started looking at our cancer survivorship clinic, which we established in February 2017 at the Brampton Civic Hospital, at the beginning of the year, and we put together the research and preliminary findings of the study of the effects of our clinic have just recently been published in Supportive Care in Cancer, and I'm sure that Anish will be speaking to some of those results in her presentation. And so I'd once again just like to open this up and say thank you to everybody and hand you over to Anish.
Thank you for the introduction, Dr. Chasen, and I would like to thank the CCSRC for the opportunity to present during today's webinar. I'm very much looking forward to discussing the William Osler Health System Cancer Survivorship Clinic and specifically the preliminary results of this clinic. I will be proceeding with this presentation by first orienting everyone to the Cancer Survivorship Clinic, and then I will move into a discussion of the preliminary results, which we have recently published successfully in the Journal of Supportive Care in Cancer. So before going into the discussion of the clinic and the research at hand, I would like to highlight for the group the definition upon which the clinic was established. In cancer specifically, survivorship focuses on the health and life of a person with cancer post-treatment until the end of life. It covers the physical, psychosocial, and economic issues of cancer beyond the diagnosis and treatment phases. Survivorship includes issues related to the ability to get health care and follow-up treatment, late effects of treatment, secondary malignancies and cancers, and quality of life. In survivorship, family members, friends, and caregivers are also considered part of the survivorship experience. The clinic was introduced at Brampton Civic Hospital on February 6, 2017, and became the first fully comprehensive survivorship clinic in the GTA. The Cancer Survivorship Clinic was established to provide patient-centered care for patients in transition between oncology and family physicians, for patients who have completed their anti-cancer treatments and are in disease remission. So as of August 2019, a total of 665 unique consults have been made, and of these, a total of 174 patients have been discharged to the care of a family physician with the opportunity to return to the care of the clinic if necessary. The survivorship program aims to provide patients with interdisciplinary care, which focuses on providing psychological, social, information, emotional, and practical support. And the dynamic team of physicians, nurses, and social workers provide patients with a more integrated approach to care with the goal of improving their quality of life. The opportunity for referrals to other supportive services, such as dietitians, can also be arranged through the clinic, and overall, patients are provided access to support in the environment and the tools they need in a single space to assist them in the transition from sickness to health. Survivorship care plans are also created in consultation with patients and families for ongoing treatment and for monitoring of needs. These care plans may be used personally by the patients, and they can also be shared with family physicians and others involved in their care. So within the interdisciplinary team, the nurse is required to take on a leadership role in the functioning of the clinic. The nurse meets with patients in person upon referral from oncology to collect initial distress thermometer readings and to explain the role and the purpose of the survivorship clinic as it pertains to each individual patient. So on the day of the first appointment, the nurse repeats the distress thermometer measurement and obtains weight and vital signs. The nurse also completes a brief assessment, which allows him to discuss the patient's specific circumstances, concerns, and any issues that are evident. Post-physician assessment, the nurse coordinates follow-up requirements, including but not limited to ordering scans, blood work, or social work referrals. He also works to organize external referrals for specialists such as GI or surgery, and the nurse is the first and the continuous contact for patients and becomes the go-between the patient and the physician. So now moving on to the role of the physicians. The physicians are actively involved in screening for disease recurrence, comorbid conditions, as well as secondary malignancies. They work to evaluate and discuss all volunteered psychosocial issues after reviewing the questionnaires completed by the patients. The physicians also review medication lists and write referrals for genetic testing if and when required, and they may also refer patients back to surgeons, oncologists, and radiation therapists based on the findings of their assessments and ordered tests. And the physicians also make significant efforts to discuss complementary and integrated treatment options. Patients who are distressed and self-identify or who demonstrate signs of depression, anxiety, and or suicidal thoughts or are having difficulty adjusting to life post-treatment are directed to the attention of a social worker. And the social worker plays a significant role in providing patients with information about social housing, available government financial assistance, as well as drug benefits where necessary. When concerns arise, the social worker is involved in safety planning and community referrals for domestic violence concerns and provides access and links to substance abuse resources. The primary role served by the social worker is in providing psychosocial support and referrals to the community counseling for ongoing support. So common topics of discussion that often arise with the social worker include financial issues, family problems, emotional problems like depression, anxiety, and self-harm concerns, sexual issues, legal concerns, as well as concerns related to spirituality, faith, and religion. She explores the concept of self-care in collaboration with patients and explores the possible support systems that are available. Not only does the social worker address the concerns of the patients, but rather she also assists caregivers in accessing the resources and supports necessary in their role as part of the care team. What is also important to note is that most patients that are seen through the survivorship clinic also take on the role of caregivers for someone else, either as a mother or father or as sons and daughters. They share concerns and receive support with respect to the issues and difficulties they face related to these roles and responsibilities, which are further complicated by their own personal cancer recovery journey. So the transition from active oncological treatment to life can be a pretty significant leap for most individuals. And the survivorship clinic has taken on the role of an intermediary between the two to fill the care gap and provide patients with well-informed support and guidance. Patients may find themselves feeling helpless and neglected after cessation of oncological treatment due to their personal lack of information about where to access support and resources, and possibly due to a rapid transition to a family physician who may not particularly have the specific expertise or access to supports and resources required to meet the diverse needs of cancer survivors. So I'd like to highlight and go through the clinic procedures briefly, and starting off with the referral, which we've highlighted as T0. Patients are introduced at this point in the process to the function of the clinic. Survivorship care plan details, distress thermometer, Canadian problem checklist, and the Edmonton symptom assessment skill are all completed. Currently, referrals are directly made by the William Osler Health System Oncology Department. Moving on to T1, the baseline consultation. Patients' specific concerns are discussed and recorded, and the questionnaires, again, the same ones that were mentioned earlier, the DT, CPC, and ESIS are retaken. The physician then systematically examines the patient and assesses disease status and complications following anti-cancer treatment. In addition, the physicians investigate patient-specific comorbidities, risk for secondary malignancy, relapse risk, and the need for social worker intervention. And T2 to TX, as you will note here, are follow-up visits, and all of these subsequent follow-up visits involve questionnaires that are repeated, and standard physician examination protocols are conducted, as was discussed with regards to the baseline consultation. You'll note here that the Cancer Survivorship Clinic at William Osler has forged a strong and formal partnership with Wellspring Chinguzi. And Wellspring provides a variety of supportive care programs for individuals living with and recovering from cancer at no cost to the patient. So Wellspring is funded entirely through donor generosity, either at the individual or corporate level, and Wellspring receives no additional government or hospital funding supports. And there are a variety of different programs offered to patients, including programs that you'll note on the right of the screen, including brain fog, cancer exercise, cooking, and meditation. And all willing patients that come through the Cancer Survivorship Clinic are referred to the Wellspring Center in Brampton to access the numerous support services that are available within the single premises. So this may have already been evident based on the previous slides and what we have covered thus far, but I'm hoping to clearly articulate that the clinic and all of the elements work with the understanding that each patient with their unique lived experiences arrives at the clinic with distinct needs that may only be effectively addressed through cooperative efforts of an experienced interdisciplinary team. So based on the variable needs of patients and their families, the physicians, the nurse facilitator, and social workers work together to provide essential supports and resources on the road to physical and psychosocial recovery. And they could be also referred to local community partners for further support and are facilitated in their transition back to their family physician, who continues with regular clinical examination and standard follow-up laboratory and radiological examinations. And once patients are referred to the Cancer Survivorship Clinic, an open communication channel is maintained with the referring medical oncologist. And should the patients require further support in that respect due to relapse or secondary malignancy, they would be channeled back to their oncologist. So moving on, looking at the transition to life post-cancer. So upon completion of clinic intervention, and when deemed appropriate by the care team, patients are referred to the care of their family physicians to continue to receive the support that they require in the community. So we have identified that the key to success in this particular transition is to educate not only the patients, but also family physicians about what to expect and what to look for in these patients moving forward. And the clinic team has also undertaken responsibility to have these patients seen urgently should there be any suspicion of recurrence or the need for any additional supports that can be provided by the clinic. And now I will begin transitioning into the discussion relevant to the concepts that are discussed in the research at hand. So distress is a phenomenon which is commonly observed among cancer survivors. It can also be seen among patients of other conditions as well, but specifically is of particular concern for cancer survivors. And distress is frequently referred to as the sixth vital sign in a significant portion of the literature. And it has been defined as, and I quote, a multifactorial, unpleasant emotional experience, which extends along a continuum ranging from common normal feelings of vulnerability, sadness, and fear to problems that can become disabling, such as depression, anxiety, panic, social isolation, and existential and spiritual crisis. So the Canadian Partnership Against Cancer endorses distress screening, which addresses both physical and psychological symptoms. And this goal and this aim can be achieved through the use of the distress thermometer, herein referred to as the DT, the Canadian Problem Checklist, CPC, as well as the Edmonton Symptom Assessment System, or scale, which is referred to as ESIS going forward. The specific study objectives of the present study were to determine the changes in patient DT scores and CPC results following cancer survivorship clinic intervention, and we also hope to assess changes in patient ESIS scores following intervention of the clinic. So in terms of study design, we undertook a single-centered prospective chart review through which we studied the charts of 176 patients who have or continue to receive support through the Cancer Survivorship Clinic. Patient data was collected during the time frame of February 2017, when the clinic was introduced, to May 2018. In the next few slides, I will go through the demographic background of the study population, and of the 176 study patients, the majority, 88%, were female, and between the ages of 51 to 70, that made up 64% of the study population. Looking at cancer diagnoses, breast cancer was the most common cancer diagnosis, 85% of the study patients, in fact, followed by colorectal cancer, which was observed in 11% of the population. And patients with, I'd like to note that patients with any cancer diagnosis are eligible for a consult to the Cancer Survivorship Clinic. And as some of you will probably be paying attention to the disproportionately higher breast cancer survivors, is simply attributed to the fact that those were the patients that were referred to the clinic by the medical oncologists, and not because of a bias towards any particular diagnosis that receives care through the clinic. Moving on, in terms of cancer staging, the majority of breast cancer survivors, 79%, had an initial staging of either stage 1 or stage 2 cancer, which you'll note on the left of the screen, and on the right is the staging with respect to colorectal cancer survivors, and the majority of the survivors were initially diagnosed with stage 3 cancer. You will also note in the yellow, 10% of the patients with colorectal cancer, equivalent to 2 of the study patients, were diagnosed with stage 4 cancer. However, in both of these 2 particular cases, the tumor was completely resected surgically. And moving on now into a discussion of the distress thermometer results and the problem checklist. So patients receiving care through the survivorship clinic self-report their experienced distress on a scale of 0 through 10 using the distress thermometer, which is accompanied by a problem list through which patients are able to identify the specific problems contributing to their distress. So as you will note from this particular graph, specifically looking at the 2 bars on the left, the mean DT score of patients in the study population during the baseline visit, T1, was 3.3, and during the follow-up visit, T2, the mean reported distress thermometer score was reduced to 2.9. A student's t-test was completed, which revealed that there was a statistically significant decline in the distress scores among the study population. And further to that, we undertook an analysis of a subgroup within the population, so patients with an initial reported distress score greater than or equal to 4, who have been identified as high-risk patients based on the literature, and revealed that the mean distress thermometer score among the subgroup was 5.5 at T1, and at T2, the mean reported distress thermometer score declined to 4.2 during the follow-up visit. So again, a study as a student's t-test was completed, and it revealed that there was an extremely significant decline or reduction in the distress thermometer scores among this particular subgroup from T1 to T2. So now just looking at another perspective on the distress thermometer scores, and another way to consider these scores is to assess the overall mean distress score among the individual visits. And while the numbers indicate a slight reduction in distress scores from visit 1 to visit 2 among patients, there's a relatively large increase, which you'll note at visit 3, going from 2.9 to 3.6 at visit 3. And initially, this may appear as though patient distress is increasing on a whole. However, this increase may be attributed to the clinic protocols by which most patients who appear to have adjusted to their condition and require limited in-person support are transitioned to the care of a family physician, usually at visit 2. And as such, patients who are at higher risk of distress and require more support continue to be seen by the clinic, they are the patients that end up entering visit 3 and beyond. And from an equity perspective, this provides indication that the clinic has been able to identify and retain patients who require greater support through subsequent follow-up visits. So moving into the Canadian problem checklist, and this checklist works to identify the source of patient-reported distress. And as you can see from the table, among the general study population, the 5 most commonly reported causes of distress, you'll note on the left of the table, include pain with 43% patients, anxiety 42% patients, fatigue among 40% patients, tingling hands and feet for 40% of patients, and sleep or insomnia issues for 36% of patients. So in addition to these commonly reported causes of distress, you'll note from the table that patients also have the option to select a number of other problems that apply to them specifically, including practical problems, family problems, emotional problems, physical problems, as well as spiritual, as well as religious problems. And all of these are addressed when they are self-reported by patients during the clinic visits. So again, looking specifically at the CPC results, among patients with a baseline distress thermometer score between 4 to 7, there were 48 patients among this group. The top reported causes of distress on the CPC included anxiety, pain, fatigue, sleep, and depression. And patients with an initial distress thermometer score of greater than or equal to 8, you'll note on the right of the table, this was a total of 22 patients. The similar problems appear with fatigue taking precedence among most patients, with 73% patients, followed by anxiety, pain, sleep, insomnia, and tingling in the hands and feet. So across the board, we see that common issues reported most frequently by patients are pain, anxiety, and fatigue. The Edmonton Symptom Assessment Scale, ESIS, is a tool which may be used by patients to self-report the severity of a number of physical and psychosocial symptoms, including pain, tiredness, nausea, depression, anxiety, drowsiness, appetite, well-being, and shortness of breath. So all of them are found on the left side of the sheet. Moving on to the actual results. So during the baseline visit at T1, the mean scores that I'll list out for the patients. So reported was pain at 2.4, tiredness was 3.4, nausea was 0.7, depression 1.8, anxiety 2.3, drowsiness 1.5, appetite 0.9, and well-being was 2.8, and shortness of breath at 0.9. So moving on from T1 to T2, which is a follow-up visit, there was a reduction in the mean reported score for all symptoms, as patients reported 2.1, a mean reported score of 2.1 for pain, 2.8 for tiredness, 0.3 for nausea, 1.0 for depression, 1.5 for anxiety, 1 for drowsiness, 0.7 for appetite, 2.4 for well-being, and 0.9 for shortness of breath. So there was a reduction in self-reported symptom severity across the board, but particularly there was statistically significant declines observed in the score for all symptoms, with the exception of appetite and well-being. Moving on, so in addition to these 3 assessment scales that have been discussed just previously, in addition to those, the clinic has also employed a number of supplementary assessment tools, including the Patient Health Questionnaire 9, PHQ 9, Generalized Anxiety Disorder 7, GAD 7, as well as the Cancer Fatigue Scale, or referred to as the Sleep Quality Assessment, PSQI. So the PHQ-9 is a useful tool in screening, diagnosing, and monitoring depression severity. In terms of utility, this tool has been easily implemented into the clinical practice to get a better understanding of depression among the relevant patients. So PHQ-9 is an assessment tool which can be triggered with an ESIS depression score of 3. Moving on to GAD-7, as the name implies, acts as a screening tool for generalized anxiety disorder and allows patients to self-report the qualitative severity of various signs of anxiety. And the GAD-7 is triggered upon observation of an anxiety score of 2 reported on ESIS. Moving on to sleep quality assessment, also known as the Pittsburgh Sleep Quality Index. This is also an effective tool in measuring quality of sleep and sleep patterns in adult populations, and has been implemented to address an issue that is consistently among the top concerns reported by patients through the Canadian Problem Checklist. And this intervention is triggered upon observation of a fatigue score of at least 4 on the ESIS. So on a whole, the ESIS acts as a useful quick screening tool, which provides scores that can trigger further PHQs, assessment tools for a more in-depth understanding of patient-specific pain, depression, anxiety, as well as fatigue. So now I would like to everyone to kind of pay particular attention to the next few slides. Our recently published paper focuses primarily upon self-reported assessment tools, including the DT, CPC, as well as ESIS, as was outlined in our initial objectives. However, throughout the research process, we remain consistently mindful of the importance of consideration of different forms of evidence, given the interdisciplinary, patient-centered care model of the clinic. And while the assessment tools act as a standardized mean of assessing distress and symptomology, it's very important to consider the patient perspective as a form of qualitative data that must be included to study the clinical relevance of the present findings, which in and of themselves are unable to completely portray or illustrate the unique lived experiences of the relevant patients and the survivors who are seen through the clinic. So as you can see on the screen, there is an image of what has been used. Recently, the FamCare P16 survey was modified, and it is a validated patient and caregiver satisfaction measurement tool, which includes 16 questions. And for our specific purposes with respect to the Cancer Survivorship Clinic, this was modified to include relevant or questions to address this. And this tool was used to study patient satisfaction, which is an important factor to consider, as I've mentioned earlier, in order to get a holistic view of the clinical care outcomes. So as observed on the previous slide, the scale, I'll just move back to that, allows patients to rank their satisfaction on a scale of 1 to 5, where 5 indicates very satisfied with the relevant element of care. So just a brief glance at this table will make it evident that across the board, mean patient satisfaction lies somewhere between satisfied to very satisfied with respect to the variety of elements that form part of the care that patients receive through the clinic. And this includes everything from the care team's attention to symptoms, information availability, emotional support, availability for practical supports, to involvement of family and care decisions. And now moving into the conclusions. So patients on a whole had a reduction in distress from the initial visit to the follow-up visit, particularly when we note high-risk distress patients with an initial distress thermometer score of greater than or equal to 4. These patients experienced an even more significant reduction in distress compared to the study population. And it's also noteworthy that the reduction in patient distress was independent of the number of visits to the clinic, and this is likely supported by the equitable care model employed by the clinic. And basically, there's an emphasis placed on the need for continued focus on visit quality over something such as quantity or frequency of visits. Moving on to average reported distress scores. So there was an increase that was observed from visit 1 to visit 3. However, based on the clinic protocols as well as the available data, this may be attributed to the fact that patients with increased distress and care needs continue to receive care through the clinic in subsequent follow-up visits with aims on pinpointing the source of their distress and to identify appropriate and sustainable supports to address the concerns. The top 5 causes of distress that were identified using the CPC include pain, nervousness, anxiety, fatigue, tingling in the hands and feet, and sleep or insomnia. And the top 3 symptoms reported during the baseline visit on the ESIS include tiredness, well-being, and anxiety. And there is a significant decline in average scores or mean scores reported on the ESIS from the baseline visit to the follow-up visit. And specifically looking at patient satisfaction, which is a factor or a variable that we're considering more recently, there is an indication that there is relatively high patient satisfaction with respect to various elements of care, ranging from satisfied to very satisfied based on what we saw with the table. So moving on to the implications of the current findings for survivors, and with respect to this, it is evident that continued active clinical support as well as education for cancer survivors should be considered as a potentially essential element in the cancer treatment trajectory in order to address patient distress and to seek patient well-being as a desired state of comfort and health. And we are presently entering a very new and a very exciting era of integrated health systems that facilitate access to the resources that support patients through their recovery and beyond. And when considering the future of survivorship, the focus is now moving towards treatment of patient symptomology and distress with the correct interventions in the right amount, at the right time, at the right place, and for the right patient. And looking into the future directions, given the novelty of the Cancer Survivorship Clinic here at Brampton Civic Hospital, the results of the study are just as they have been entitled, preliminary, and we hope to use these promising findings as a catalyst for continued research into and clinical implementation of some of the future directions that we've included and listed here. So I'll just list off briefly some of the considerations that we have, including ensuring that all patients receive care through the William Osler Health System Cancer Survivorship Clinic that is tailored to address their patient-specific symptoms that contribute to distress. Next, we're also considering the implementation of a method of conducting more frequent assessments, not particularly through more frequent visits, possibly through considerations upon remote patient monitoring to facilitate a better understanding of patient distress. Further to that, we would like to assess the feasibility of making the survivorship clinic accessible and available for all patients surviving cancer through infrastructure expansion and increased resource allocation. And specifically looking at the area and where we are currently located, given the diverse patient population, there is a consideration and thought given to making screening and assessment tools accessible to patients in a language as well as in a context that is easiest for them. We would like to continue to conduct qualitative investigation of patient-specific care experiences through the clinic, and further to that, develop solid discharge criteria specific to the clinic as well. And moving on, for anyone that is interested in getting a more in-depth look at the present research study, an accessible shareable link is included at the bottom of the slide. So if you use that link, you should be able to access the article. However, the functionality of the download and print buttons is not there. but I'm sure you can access it through other databases as well if you prefer. And with respect to questions, if you have any questions following the completion of the webinar, you can get in contact with either myself or Dr. Chasen at the 2 emails addresses that have been listed on this slide. And at this time, I'd just like to thank everyone for taking time out of their very, very busy schedules to attend today's webinar to learn about the preliminary results of the effects of the cancer survivorship clinic. So thank you, everyone.